Hi guys, in this lesson we're going to cover continuous passive motion, which is a common post-surgical management technique. It is exactly what it sounds like. It's called continuous passive motion because it is the opposite of immobilization. So sometimes following surgery, someone may be immobilized, put in a brace or put in a cast or any type of other equipment that's going to stop motion. But CPM is actually giving the patient motion somehow, or facilitating motion somehow in that post-surgical period. So it helps to limit some of the negative effects of immobilization, like stiffness and soreness and shortening of soft tissue and things like that. So CPM is going to deliver gentle stress to the tissue, and it is predominantly used for knee injuries. So if you guys ever see a CPM machine, I can almost guarantee you it's going to be for the knee, and most often following a total knee replacement. Can be used following other knee surgeries, but that is by far going to be the most common. They do have units for the hand, wrist, hip, shoulder, elbow, and ankle as well, so all the other major joints of the body. So this is essentially what a CPM unit is going to look like. It is a large unit, so immediately post-surgery, the person's going to need help getting in and out of this thing. So if they're in the hospital, oftentimes nursing will help with this, or us in therapy, we can help. At home, they'll have to have someone there to help them if they're going to use it at home following surgery. But it just sits up on the bed with them. There is a little remote control here that controls the amount of flexion that's going to be introduced into the knee. And we just go nice and slow with this, introducing a couple more degrees of flexion each day. And then their leg can just sort of rest on top of this, and then the machine will just bring it from full extension up into whatever degree of flexion you set in the machine. So these would be some of the units for the other parts of the body, the elbow, shoulder, the wrist, and the hand. Like I said, they have them for pretty much all the major joints, but we predominantly use it for knees. So we will see if this is going to show on the slideshow. So this is just showing what a CPM looks like, and here's one in actual use. So you can see it's just very slow, controlled movement. This is actually in quite a bit of flexion, so we would obviously not start putting the person's knee into that much flexion, but they can also control, they can increase or decrease the amount of flexion to their comfort as well. So a person would use this, again, immediately post-op for a couple hours potentially at a time, or multiple times throughout the day to add up to several hours altogether. Okay, so this was designed by a physician. Again, the benefits of this is that it will help to enhance the nutrition of articular cartilage. Articular cartilage is pretty much avascular, and it's nourished by the movement of synovial fluid. So if a person is immobilized following a surgery, that synovial fluid is not going to be moving around, and so
My
the
name's Sean
articular
Willis,
cartilage.
at University Hospital, London Health.
All right, let's try this again without YouTube jumping into the background. So again, we're going to provide that nutrition and nourishment to the articular cartilage if it's still there. It will also sort of stimulate tissue remodeling and regrowth in the natural planes of movement. So if you think back to Wolff's Law and why that was important, again, Wolff's Law pertains to bone and how it remodels according to lines of stress. That can be extrapolated to other tissue as well. So if you think about the healing tissue around a total joint replacement, if the knee is flexing and extending as it's healing, that collagen is going to be laid down in a less random order, right? It'll be laid down along the lines of stress, which again for the knee is flexion and extension. CPM has also been shown to accelerate the healing of cartilage, tendons, and ligaments, so we may actually even speed up the healing process following surgery. So there's a couple of different types of CPM machines. If you are going to see one, I believe that you will see the anatomic type of CPM machine. It attempts to mimic the natural motion of the knee. It is the one that's most suitable for the knee. They also have a free linkage, which just doesn't support the joint as much. If you think back to those pictures, you could see that the leg was very supported throughout the treatment there. So with free linkage, there just isn't as much support for the limb. Non-anatomic, I'm not sure why these exist really, but they don't really replicate natural joint motion because they allow for compensatory motion, and there is a difference between the degrees that you program into it and what's actually occurring. So as far as the effects on the injury response process, again, this is going to encourage remodeling of the collagen and the new tissue that's being laid down along the lines of stress, again, which would be more random if the leg was immobilized because there would be no stress on the structure then. It reduces the negative effects of immobilization, so the tightening of the hamstrings and the other musculature around the area. The joint capsule itself, which could become a problem down the road with knees, especially needing manipulations and things like that. And it can help to increase the tensile strength of the healing tendons, allografts, skin in the area. There is also a slight pumping effect, which may help to reduce edema. This is passive motion, right? Remember we talked about active motion being required to actually reduce the amount of edema, getting those muscles to contract and actually pump out the fluid. So because this is an active motion, this is passive motion, but just having the knee moving a little bit is better than having it not moving at all as far as allowing edema to form. So the biggest effect of this machine is going to be its effect on range of motion. So it does allow for earlier active range of motion for that patient, also allows for earlier strengthening for that patient. What they have found out is that those people, patients who have CPM and those who don't have CPM, turn out pretty much the same over the course of time. So usually about 6 months to a year later, there's really no difference between people who had CPM and those who didn't have CPM. My thoughts with that are, like, if you've ever been injured, you want to be better tomorrow. So the sooner we can get people feeling better, typically the better off they are. So this just sort of helps to speed up that whole process. We're usually going to increase the range of motion about 6 to 7 degrees per day. So like I said, it's just a really slow increase gradually over time. So think about what 6 to 7 degrees would look like on a goniometer. It's not a lot. Again, this can help improve range of motion by reducing soft tissue restrictions, right? So it's not allowing all the soft tissues to shorten up by being immobilized. It increases total end range time. So again, it takes them up into knee flexion, holds them there for a couple seconds, and then returns them back into extension. This is also really nice for our patients who have significant cardiovascular issues who aren't able to get up and walk. Immediately following total knee replacements, we do want to get people up and walking right away, but if they have a lot of pulmonary issues, cardiac issues, that might not be feasible because it's going to take a lot more effort to walk now using an assistive device and just getting around. So this can be very beneficial for those patients. We mentioned joint nutrition earlier. Again, meniscal cartilage, articular cartilage doesn't have a lot of blood supply, so they get most of their nutrition from the movement of synovial fluid. So again, if the leg is immobilized, they're not going to be getting a lot of nutrition. So CPM can help to introduce that gentle movement and allow some nutrition back into the cartilage. CPM has also shown better functional outcomes early on than just doing active range of motion, because active motion, again, we're forcing the muscles to work, and those muscles have just been traumatized by surgery. So again, if we can do it passively and still get some of those same benefits, that's going to be helpful for the patient. Again, with edema reduction, this is probably not going to be the best device to try to relieve edema. Again, initially following a total knee replacement, your patients are going to love ice packs. So keep those coming. Give them ice packs. They can probably even wear one while they're on CPM. Again, this is passive, but again, just in keeping that knee moving, it does help a little bit with limiting edema formation. And they have done some studies where they have found edema reduction following total knee and ankle replacements, ACL reconstructions, and hand edema following different hand surgeries as well. Pain reduction, again, this is not intended to be a pain relieving device. Most patients do not mind it though. They find it kind of comforting, just that gentle motion, just to get them moving a little bit. Again, if we're reducing edema, we're reducing muscle spasm, that can help to decrease a person's pain. But again, these are generally going to be people who just had a major surgery, who are going to be in some pain, and so they will need to continue normal pain relieving techniques, medication, e-stim, heat, ice, all of that will work as well. Ligament healing, if there's only one ligament involved, this might be viable. So like for your patients with ACL reconstructions. I've not seen this used too much in this area for patients with following ACL reconstruction. Part of it is you do need to be careful, and if you look down to the third bullet, when you bring that knee up into flexion, that's going to introduce some anterior translation of the tibia, and we want to be very, very cautious with that immediately post-op for our ACL patients, because that's what the ACL does. It limits anterior translation of the tibia. So we don't want to overstress that right after surgery. Again, initially range of motion is going to be increased, but there's not so much long-term difference. Again, I think some physicians are the ones who are going to prescribe CPM machines. I think some see that and decide that they're not going to spend the money or the time putting their patients on CPM in the beginning. But again, there are some definite benefits of using this early on and just getting that patient moving a little bit. So contraindications, this is a pretty easy list actually. If you don't want the joint to move, don't put it on a passive motion machine. Don't overstress the healing tissue, so make sure you're following guidelines, protocols, anything like that as far as how much flexion you're introducing into the knee. If they have an unstable fracture that has not been set or healed yet, don't be moving it around. If they have spastic paralysis, this is usually following some type of central nervous system disorder like a stroke or brain injury. CPM really isn't going to help a whole lot with that. The person is just going to fight it the whole time. Or if they have an uncontrolled infection, again, with the moving of the limb, we might have some unwanted circulation of that infection. Precautions, if they have a history of DVT, again, if they have an active known DVT, we're not going to be doing CPM. We want them to be anticoagulated, medically managed before we start to move them around. If they've had a history, they are more likely to develop another one, so just use caution with them. If they have any skin irritation from the straps, you don't necessarily have to use them, or just put a towel or a pillowcase there to buffer them for that. Your book, again, always ends up with controversies in treatment. There's not a lot of controversy about CPM. It really can work. It's not been proven more successful than manual therapy, like passive range of motion. But here's a machine that can do it so that you as the therapist don't have to sit bedside and passively range a person's knee for hours at a time. There have been some studies that found CPM decreased the length of hospital stay, although that's not super long anymore either. It decreased the need for pain meds, so that's a benefit. It gave the patients the earlier ability to perform a straight leg raise, so their strength came back a little bit sooner. The patients who had CPM had higher function scores and higher satisfaction scores when they were discharged from the hospital, and they also had a reduced need for manipulation. So if anyone is not familiar with what a manipulation is, we typically see them at either the knee or the shoulder. With the knee, it can happen after a total knee replacement. If the person doesn't get back full flexion or extension, or at least functional flexion and extension in a reasonable time frame, the surgeon may take them back into the operating room and do a manipulation where they will put the person out under anesthesia, and they will really just go in and flex the knee and extend it back out, and they'll break up all the scar tissue and adhesions. And then they typically send the person to therapy for 5 days a week for 2 weeks or so, and then back down to 2 or 3 days a week to try to maintain the gains in motion. It is a painful procedure. Patients would generally not like to have that done. So again, the more we can get them moving, the earlier, typically the better. Again, they didn't find a lot of long-term difference between those who had CPM and those who didn't, which is, again, why I think not all physicians prescribe these. But again, we are seeing some earlier benefits, which I think is beneficial for the patient. All right, that's it. Let me know if you guys have any questions. Thanks.